Hello everyone. Today's presentation will be covering fetal development, antenatal screening and monitoring throughout pregnancy. Before we begin, here's a brief overview of today's presentation. I'll start by explaining how pregnancy begins following the development from fertilization through to birth. I'll then discuss how healthcare professionals monitor the baby's well-being during pregnancy and labour, including when intervention may be required. Next, I'll explore the screening tests offered during pregnancy for chromosomal and inherited conditions before finishing with miscarriage and medical and surgical termination of pregnancy. These can be sensitive topics, so I'll present them factually using current evidence and guidelines while recognising the importance of compassionate, person-centred care. This slide here from Oliver in 2023, as well as the image here from Cleveland Clinic 2026, shows the progression of a zygote from day one up into a blastocyst, which embeds into the uterine lining. This marks the beginning of a successful pregnancy, and that's when it's clinically recognised. Following implantation, the embryo enters the embryonic period from weeks 3 to 8, as shown in the images here from Marple 2026 and Marcella 2025. This is the stage where almost all major organs develop through organogenesis. According to Hill in 2026, this is also the period of greatest vulnerability to teratogens, including alcohol, certain medications, recreational drugs, and infections, because organs are actively forming. During week 3, gastrulation forms 3 germ layers. The ectoderm develops into the brain, spinal cord, nervous system, and skin. The mesoderm forms structures such as the heart, muscles, bones, and kidneys, while the endoderm forms the digestive and respiratory systems. By week 4, the heart begins beating and the neural tube closes to form the brain and spinal cord. Cleveland Clinic 2026 explains this as why folic acid is recommended before conception and during early pregnancy to reduce the risk of neural tube defects such as spina bifida. Between weeks 5 to 7, the limbs and facial features, placenta and umbilical cord continue developing, and by week 8, all major organ systems have formed and the embryo begins making small spontaneous movements. From week 9, it is known as a fetus, with development shifting from organ formation to growth and maturation. This slide here outlines the placenta and the supporting functions. This image here from Cleveland Clinic 2025 just shows the internal structure the internal structures that are in place to support the baby throughout pregnancy. We'll move into fetal development during the first trimester, covering weeks 9 to 12, as shown in the image here by Marcella in 2025. The embryo is officially now known as a fetus, with development focusing on growth and maturation. According to Robertson in 2022, facial features become more recognizable, fingers and toes separate, fingernails begin to form, and ossification continues. The external genitalia also becomes more distinguishable here, although sex cannot always be identified reliably on an ultrasound. Physiologically, Cleveland Clinic in 2024 explains the heart is now fully full-chambered. The kidneys begin producing urine and the liver produces red blood cells before this role transfers to the bone marrow later in pregnancy. Between weeks 10 to 12, the placenta becomes fully functional in the luteal placental shift. Cleveland Clinic 2025. According to Hill in 2026, sensory development also begins as reflexes develop, touch receptors form, and spontaneous limb movements occur, although these are still too small for the mother to feel. The images here from Marcella in 2025 and Marple in 2026 show the rapid growth approximately from the size of a grape at week 9 to the size of a lime by week 12. The second trimester from weeks 13 to 27 is a period of rapid growth, with organs continue to mature in preparation for birth. The image here by Marcella in 2025 shows a visual representation of a 20-week fetus. According to Hill in 2026, the skeleton strengthens through continued ossification, muscle tone improves, and movements become stronger and more coordinated. Languor develops to help hold vernix cassella against the skin, protecting it from prolonged exposure to amniotic fluid, while the eyebrows and eyelashes also become visible. Physiologically, The lungs continue developing in preparation for breathing after birth, although they are not yet fully mature. The baby continues swallowing amniotic fluid to support digestive system's development, while the kidneys produce urine, contributing to the amniotic fluid volume. During this trimester, the bone marrow gradually takes over blood cell production from the liver. Hale in 2026. Sensory development also progresses rapidly. Hearing develops, allowing the baby to respond to familiar sounds and voices, particularly the mother's. That was by research suggested from Vegas in 2026. The eyes begin responding to light, sleep and wake cycles develop, and quickening usually occurs between weeks 16 to 24 when the mothers first feel fetal movements. Cleveland Clinic 2024. The images by Marcella in 2025 and Sawyer in 2025 illustrate growth from approximately the size of an avocado at 16 weeks to the size of a cauliflower at 27 weeks. Another important milestone is the 20-week anomaly scan, where healthcare professionals assess the baby's anatomy, placenta, amniotic fluid, and overall growth to identify structural abnormalities and plan appropriate care if needed, from Cleveland Clinic 2024. The third trimester, from weeks 28 until birth, focus on the final growth and organ maturation. According to Hale in 2026, the baby gains weight rapidly as fat is stored beneath the skin, helping to regulate the baby's body temperature after birth. The brain continues developing rapidly, while skull bones remain flexible to allow molding during labour. Most babies also move into a cephalic or head down position ready for birth. Physiologically, lung maturation becomes the priority. Increasing amounts of surfactant are produced, preventing the alveoli from collapsing after birth. The baby also receives maternal antibodies through the placenta, providing passive immunity during the first few months of life. The digestive system continues practicing swallowing movements while sleep and wake cycles are becoming more established. Sensory development is now well advanced. Hill in 2026 explains that the baby responds to light, familiar voices, touch, and external sounds, reflecting continued maturation of the nervous system. The images here by Sawyer 2025 and Blandin 2025 demonstrate the significant increase in size between 28 weeks to 40. By around 37 weeks, pregnancy is considered early term, and 39 to 40 weeks, the baby is usually fully developed and ready for birth. Overall, the third trimester prepares the baby for independent life outside the uterus by completing maturation of the vital organ systems. This slide here just outlines the routine antenatal appointments available during pregnancy. NHS England 2026 just gives a kind of guideline of what is available. According to the Cleveland Clinic 2026, ultrasound scanning uses high-frequency sound waves to produce real-time images of the baby without exposing the mother to baby to radiation. There are two main types of ultrasound: transabdominal or external, and transvaginal or internal. A transabdominal scan is performed by moving a probe across the mother's abdomen using an ultrasound gel. It is used throughout pregnancy for dating, anomaly, and growth scans because it is non-invasive, comfortable, and provides a wide view of the uterus, placenta, and baby. However, image quality can be reduced by factors such as maternal BMI or very early pregnancy. This is research supported from the Cleveland Clinic 2026. In these situations, a transvaginal ultrasound may be recommended. According to Cambridge University Hospital's NHS Foundation Trust, a narrow probe is inserted into the vagina, producing clearer images during early pregnancy. It is commonly used to confirm early pregnancy, investigate bleeding, assess cervical length, or diagnose ectopic pregnancy. Although it may cause mild discomfort, it is considered safe, and any light spotting afterwards usually settles quickly. Rather than one method being better than the other, both scans complement each other, allowing clinicians to choose the most appropriate investigation based on the gestational and clinical question being asked. Another routine method of monitoring fetal growth is the fundal height measurement, which Cleveland Clinic 2025 recommends from around 24 weeks gestation. As shown in the image here by Miles in 2025, the midwife measures the distance from the symphysis pubis to the fundus of the uterus. To improve accuracy, the woman is asked to empty her bladder beforehand. After 24 weeks, the measurement in centimeters usually corresponds closely to the number of weeks pregnant. Rather than relying on one single measurement, each result is plotted on an individual growth chart, such as the example from the Perinatal Institute, allowing changes in the growth to be identified over time. According to Cleveland Clinic 2026, measurements smaller than expected may indicate fetal growth restriction, polyhydramnios, or incorrect pregnancy dating, while larger measurements may suggest polyhydramnios, a large for gestational age baby, multiple pregnancy, or uterine fibroids. All these findings are not diagnostic and they indicate that further investigation may be required. Fundal height measurement is quick, inexpensive, and non-invasive. However, factors such as maternal BMI or multiple pregnancy can reduce its accuracy. So abnormal findings should always be followed up with an ultrasound. This demonstrates why fundal height is an effective screening tool, but should always be interpreted alongside other clinical assessments. Doppler ultrasound assesses the baby's well-being by measuring blood flow rather than simply examining anatomy or growth. According to Medicover in 2024, it evaluates circulation between the placenta, the mother, and the baby, helping identify whether the baby is receiving enough oxygen and nutrients. It is mainly used in higher risk pregnancies, including suspected fetal growth restriction, preeclampsia, diabetes, reduced fetal movements, multiple pregnancy, and previous placental complications. The image here by Paldini in 2024 shows an umbilical artery Doppler. The red and blue colours represent the direction of the blood flow, not oxygenated or deoxygenated blood. According to Bide et al. In 2021, increased resistance or absent reverse endostolic flow may indicate placental insufficiency, increasing the risk of fetal growth restriction or fetal compromise. Doppler assessment can also examine the middle cerebral artery. Increased blood flow to the brain, known as the brain-sparing effect, suggests the baby may be compensating for reduced oxygen levels. The uterine arteries may also be assessed where high resistance or notching increases the risk of preeclampsia and placental complications. The main advantage of Doppler ultrasound is that it can identify placental dysfunction before any clinical deterioration occurs, allowing closer monitoring or early delivery where necessary. However, it assesses blood flow only and must always be interpreted alongside growth scans, maternal observations, and CTG monitoring. This highlights that Doppler ultrasound supports clinical decision-making by identifying placental problems early rather than providing a diagnosis in isolation. We'll now move on to fetal monitoring during labour. During labour, the focus changes from monitoring the growth to assessing how well the baby is coping with contractions, as each contraction temporarily reduces placental blood flow. There are two main methods: intermittent equalization and continuous cardiotography, CTG. The method used depends on the level of risk associated with the pregnancy. According to the International Confederation of Midwives in 2017, intermittent equalization is recommended for low-risk pregnancies. The midwife listens to the baby's heart rate every 15 minutes during the first stage of labour and every 5 minutes during the second stage of labour, using a Doppler or Pinard stethoscope. It promotes physiological labour and allows maternal mobility and is associated with fewer unnecessary interventions. However, changes occurring between any assessments may be missed, so effective clinical judgment is essential. For higher risk pregnancies, Alfric et al. In 2017 recommended continuous CTG, 2 abdominal transducers continuously checking the baby's heart rate and uterine contractions, allowing clinicians to assess how the baby responds throughout labour. The main advantage of CTG monitoring allows earlier recognition of fetal compromise. However, it has relatively high false positive rate, meaning healthy babies can appear compromised, which increase the rates of instrumental birth and cesarean section. It also restricts maternal mobility and requires skilled interpretation. This demonstrates that the choice of monitoring should always balance accurate surveillance and with avoiding unnecessary intervention, ensuring care remains individualized. The purpose of fetal monitoring is not to simply collect information, but to identify babies who may not be coping well during labour and to intervene before significant compromise occurs. According to the Royal College of Midwives in 2017, closer monitoring may be required for pregnancies with additional risk factors such as reduced fetal movements, breech position, or abnormal antenatal findings. When interpreting a CTG, clinicians assess features including fetal tachycardia, brachadia, reduced variability, late declarations, and prolonged declarations. This is from the Maternal Health in 2025. The CCG shown here from Geeky Medics shows an example of late declarations, which may indicate reduced placental oxygen during contractions. However, CCG findings should always be interpreted alongside the mother's condition and the wider clinical picture rather than in isolation alone. If concerns arise, simple measures are usually tried first, including repositioning the mother onto her left side, giving intravagus fluids if required, or reducing oxytocin to improve placental blood flow. If CTG remains abnormal, further assessment may include senior obstetric review, ultrasounds, a fetal scalp electrode, or fetal blood sampling to assess the baby's acid-base status. As shown in the flowchart, care may need to escalate from midwife-led to obstetric-led, with birth expedited by ventouse forceps or emergency cesarean section if necessary. Ultimately, CCG supports clinical decision-making by allowing timely intervention while avoiding unnecessary interventions where possible. We will now move on to antenatal screening for chromosomal conditions. According to the NHS England in 2026, all pregnant women are offered screening for Down syndrome, Edwards syndrome, and Pato syndrome, although participation is entirely voluntary. As shown in the image here from Cleveland Clinic 2025, humans usually have 46 chromosomes arranged into 23 pairs. An extra chromosome results in a trisomy, causing these three conditions. The first screening test is the combined screening test, performed between 11 to 14 weeks. This combines measurement of the nuchal translucency with the maternal blood test to estimate the chances the baby has one of these chromosomal conditions. NHS England 2026. As this is a screening test, it estimates the risk rather than provides a full diagnosis. If the result indicates a higher chance, parents may be offered a non-invasive prenatal testing, NIPT, from around 10 weeks. This analyzes placental DNA circulating within the mother's bloodstream and provides a more accurate risk estimate, although it remains a screening test. To confirm a diagnosis, CVS may be offered between 11 to 14 weeks, or amniocentesis from 15 weeks onwards, highlighted by NHS England in 2023 and Mayo Clinic in 2025. Both are diagnostic tests but carry a small risk of miscarriage. This highlights the difference between screening tests and diagnostic testing, allowing parents to make informed decisions based on progressively more accurate information. This slide here just outlines the different types of chromosomal conditions that we screen for during pregnancy. Here is Down syndrome from Mayo Clinic 2024, and then you've got Edwards syndrome, Cleveland Clinic 2021, and then Pato syndrome, Cleveland Clinic 2023. These images are from the Cleveland Clinic in the last slide, and then I've just highlighted the extra chromosome that is replicated for each trisomy. I'll now use sickle cell disease as an example of inherited condition screening during pregnancy. According to Cleveland Clinic 2025, sickle cell disease affects hemoglobin, causing red blood cells to become rigid and sickle cell shaped. These abnormal cells can block blood vessels, which reduces oxygen and causes painful episodes, anemia, and recurrent infections or organ damage. NHS England in 2025 recommends that all pregnant women are offered screening before 10 weeks gestation. Testing begins with a maternal blood sample, and if the mother is found to be a carrier, the baby's father is also offered the testing. As shown in the Punnett square and supported by Cleveland Clinic 2025, if both parents are carriers, each pregnancy carries a 25% chance of an unaffected child, a 50% chance of a healthy carrier, and a 25% chance of a child born with sickle cell disease. If both parents are carriers, CVS or amniocentesis may be offered to determine whether the baby has the inherited condition. This demonstrates the genetic screening provides information rather than directing decisions, allowing families to make informed choices while preparing appropriate care if required. I'd now like to discuss fetal anemia. where the baby has too few healthy red blood cells to carry sufficient oxygen. According to Castleman et al. In 2021, severe anemia places additional strain on the baby's heart and may become life-threatening if untreated. Common causes include rhesus incompatibility, paravirus B19, twin-to-twin syndrome, and inherited blood disorders such as thalassemia. The main investigation in the middle cerebral artery Doppler, which measures peak systolic velocity. The colours shown represent the direction of the blood flow and not oxygenated or deoxygenated blood. Increased blood flow produces a raised PCV, and measurements above 1.5 multiples of the median suggest moderate to severe anemia. Further investigations may include maternal blood tests, ultrasound assessment for hydrops fetalis or chordocentesis. If severe anemia is confirmed, treatment involves a uterine transfusion of O rhesus negative blood directly into the umbilical vein under ultrasound guidance, Castleman et al. In 2021. Depending on severity, repeated transfusions or early delivery may be required. Without treatment, severe fetal anemia can lead to heart failure, hydrops fetalis, or fetal death. However, early diagnosis significantly improves survival and long-term outcomes. This demonstrates how advances in fetal medicine allow serious conditions to be identified and treated before birth, improving outcomes for both mother and baby. Miscarriage is defined as the loss of a pregnancy before 20 weeks gestation, continental hospitals. According to the NHS Inform 2026, around 1 in 5 pregnancies end in miscarriage, most commonly due to factors beyond anybody's control. Risk factors include increasing maternal age, smoking, alcohol, obesity, poorly controlled diabetes, thyroid disease, and uterine abnormalities. However, chromosomal abnormalities account for around 50 to 60% of the miscarriages and usually occur by chance during fertilization. This research was suggested by Mayo Clinic 2023 and Cleveland Clinic 2022. Science Insights 2026 describes several types of miscarriage, including missed, complete, ectopic, and molar. Common symptoms include vaginal bleeding, abdominal pain, and passing pregnancy tissue, while severe bleeding, fever, or dizziness require urgent medical assessment. NHS Inform 2026. Many people believe miscarriage is caused by exercise, sex, or stress. However, Cleveland Clinic 2022 confirms there is no evidence that these activities cause miscarriage in an uncomplicated pregnancy, making reassurance an important aspect of care. According to NICE in 2023, management options include expectant medical using misoprostol with or without mifepristone, and surgical management using manual vacuum aspiration or ERPC. Expectant is when it just passes naturally. The body will get rid of all the excess tissue, but a follow-up might be required just to check that everything's okay. This highlights that miscarriage management extends beyond clinical treatment, requiring compassionate, individualized care that supports both physical recovery and emotional well-being. I'll finish by discussing medical and surgical termination of the pregnancy. Termination may be considered for personal reasons, concerns about maternal health, or following the diagnosis of a severe fetal abnormality. Regardless of the reason, healthcare professionals provide unbiased information to support informed decision-making. According to NHS England in 2024, medical termination involves mifepristone, followed 24 to 48 hours later by misoprostol. To stimulate uterine contractions, it is most commonly used in early pregnancy, often up to 10 weeks, and may be completed at home following clinical assessment. It avoids surgery, but usually involves heavier bleeding, cramping, and longer recovery. According to BPAS, surgical termination is usually performed using vacuum aspiration in early pregnancy or dilation and evacuation after around 14 weeks. It is completed in a single procedure but carries small risks associated with surgery and anesthesia. As outlined by NICE in 2024, termination of England termination in England and Wales is governed by the Abortion Act in 1967, as amended by the Human Fertilisation and Embryology Act in 2008. Before 24 weeks, termination may be carried out if the legal criteria is met. After 24 weeks, it is only permitted in specific circumstances, including serious fetal abnormality or significant risk to the woman's life or health. Throughout the process, informed consent is essential, ensuring individuals receive accurate information and enough time to make their own decisions. Finally, aftercare is essential to safe recovery. Before discharge, patients receive guidance on expected bleeding, pain management, signs of infection, and when to seek medical help. Follow-up care, contraception advice, and emotional support may also be offered with organisations such as the Miscarriage Association, Tommy's, BPAS, and NHS abortion services, providing ongoing information and counselling. This highlights that abortion care extends beyond the procedure itself, recognising both physical recovery and emotional well-being as integral to patient-centred care. To conclude, pregnancy is a complex process that begins with fertilisation and continues carefully through the coordinated stages of fetal growth and development. Throughout pregnancy, antenatal screening and monitoring play a vital role in assessing maternal and fetal well-being, allowing complications to be recognised early and appropriate intervention to be provided when necessary. We also explored chromosomal and inherited condition screening, highlighting how tests support informed decision-making while remaining entirely voluntary. Finally, we've discussed miscarriage and the termination of pregnancy, emphasising the importance of evidence-based, compassionate and non-judgmental care. Ultimately, effective antenatal care is not about identifying complications, but also about supporting informed choice, promoting healthy pregnancies, and placing the needs of women and their families at the centre of every decision. Thank you for listening.